Major neurocognitive disorder, commonly known as dementia, represents one of the most profound and challenging conditions affecting human cognition and quality of life. This complex syndrome affects over 55 million people worldwide, with nearly 10 million new cases diagnosed each year, making it a global health crisis that touches virtually every family and community. Unlike the natural cognitive changes that occur with normal aging, major neurocognitive disorder involves significant decline in cognitive functioning that substantially interferes with independence and daily life activities, fundamentally altering not only the lives of those diagnosed but also their families, caregivers, and entire support networks. The term major neurocognitive disorder was officially adopted in the Diagnostic and Statistical Manual of Mental Disorders 5th edition to replace the traditional term dementia, reflecting a more precise understanding of these conditions as brain-based disorders with varying presentations and underlying causes. This diagnostic category requires evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains, including complex attention, executive function, learning and memory, language, perceptual motor skills, or social cognition. Crucially, these cognitive deficits must interfere with independence in everyday activities, distinguishing major neurocognitive disorder from mild cognitive impairment or normal age-related changes. Understanding major neurocognitive disorder requires recognizing that it encompasses numerous distinct conditions, each with unique underlying pathologies, progression patterns, and clinical presentations. Alzheimer's disease accounts for approximately 60 to 80% of all cases and is characterized by the progressive accumulation of amyloid plaques and neurofibrillary tangles in brain tissue, leading to widespread neuronal death and brain atrophy. The typical presentation begins with episodic memory loss, gradually expanding to affect other cognitive domains including language, executive function, and visual spatial abilities. Individuals with Alzheimer's disease often experience a slow, progressive decline over 8 to 12 years from diagnosis to end-stage disease. Vascular major neurocognitive disorder, the second most common type, results from reduced blood flow to brain tissue due to stroke, small vessel disease, or other cardiovascular pathology. Unlike Alzheimer's disease, vascular dementia may present with a more stepwise decline, where cognitive function remains relatively stable between episodes of cerebrovascular events. Executive dysfunction, processing speed deficits, and attention problems are often more prominent than memory loss in the early stages, reflecting damage to frontal subcortical brain circuits. Lewy body disease presents a unique constellation of symptoms including cognitive fluctuations, visual hallucinations, and movement disorders similar to Parkinson's disease. Individuals with this condition may experience dramatic variations in alertness and cognitive performance from day to day or even hour to hour, making it particularly challenging for families to understand and manage. The presence of detailed visual hallucinations, often featuring people or animals, can be distressing for both patients and caregivers, but represents a characteristic feature of this condition. Frontotemporal major neurocognitive disorder primarily affects the frontal and temporal lobes of the brain, leading to profound changes in personality, behavior, and language, while initially sparing memory function. This condition often strikes individuals at younger ages, typically between 45 to 65 years, causing devastating impact on families and careers. Behavioral variant frontotemporal dementia may present with loss of empathy, social disinhibition, compulsive behaviors, and dramatic personality changes that can strain relationships and lead to misdiagnosis as psychiatric conditions. The progression of major neurocognitive disorder typically follows recognizable stages, though the specific timeline and manifestations vary considerably among individuals and underlying conditions. Early-stage disease is characterized by noticeable cognitive changes that begin to interfere with complex activities of daily living such as managing finances, driving in unfamiliar areas, or following complex instructions. Individuals may experience difficulty finding words, making decisions, or remembering recent events, while generally maintaining awareness of their deficits and ability to participate in medical decisions. Middle-stage major neurocognitive disorder involves more significant cognitive and functional decline, with individuals requiring increasing assistance with instrumental activities of daily living such as medication management, meal preparation, and transportation. Memory loss becomes more pronounced, affecting both recent and remote memories, while language difficulties may progress to word-finding problems and comprehension deficits. Behavioral and psychological symptoms often emerge during this stage, including agitation, depression, anxiety, sleep disturbances, and changes in appetite or eating patterns. Late-stage major neurocognitive disorder is characterized by severe cognitive impairment and complete dependence on others for basic care needs. Individuals may lose the ability to recognize family members, communicate effectively, or perform basic self-care activities such as bathing, dressing, or toileting. Motor function often deteriorates, leading to difficulties with walking, swallowing, and maintaining continence. End-stage disease may involve loss of purposeful movement, inability to sit without support, and increased susceptibility to infections and other medical complications. Behavioral and psychological symptoms of major neurocognitive disorder, sometimes referred to as neuropsychiatric symptoms, affect up to 90% of individuals at some point during their illness and represent some of the most challenging aspects of care. These symptoms include agitation, aggression, wandering, repetitive behaviors, depression, anxiety, delusions, hallucinations, sleep disturbances, and disinhibited behaviors. Understanding that these symptoms result from brain pathology rather than deliberate actions is crucial for maintaining compassionate care approaches and developing effective management strategies. The diagnostic process for major neurocognitive disorder requires comprehensive evaluation by qualified healthcare professionals, often involving collaboration between primary care physicians, neurologists, geriatricians, and neuropsychologists. The assessment begins with detailed medical and cognitive history, preferably obtained from both the patient and knowledgeable informants who can provide observations about functional changes over time. Cognitive testing ranges from brief screening instruments to comprehensive neuropsychological evaluations that assess specific cognitive domains and help identify patterns consistent with different underlying conditions. Laboratory testing helps rule out potentially treatable causes of cognitive decline, including vitamin deficiencies, thyroid disorders, infections, and metabolic abnormalities. While most cases of major neurocognitive disorder are irreversible, identifying and treating contributing factors can sometimes improve cognitive function or slow progression. Neuroimaging studies such as CT or MRI scans can detect structural brain changes, strokes, or other abnormalities, while specialized imaging techniques may help distinguish between different types of dementia. Current treatment approaches for major neurocognitive disorder focus on symptom management, optimizing remaining abilities, and improving quality of life rather than curing or dramatically altering disease progression. Cholinesterase inhibitors, including donepezil, rivastigmine, and galantamine, may provide modest cognitive benefits and help manage behavioral symptoms in some individuals. Memantine, an NMDA receptor antagonist, may be beneficial for moderate to severe stages of Alzheimer's disease. However, it's essential to understand that these medications provide symptomatic relief rather than disease modification and may not be effective for all individuals or all types of major neurocognitive disorder. Non-pharmacological interventions often provide significant benefits and should be considered essential components of comprehensive care. Environmental modifications, including simplifying living spaces, removing safety hazards, establishing consistent routines, and using memory aids, can help maintain function and reduce confusion. Structured activities, social engagement, music therapy, and exercise programs can improve mood, behavior, and overall well-being. Person-centered care approaches that focus on individual preferences, life history, and maintained abilities help preserve dignity and quality of life throughout the disease journey. The impact of major neurocognitive disorder extends far beyond cognitive symptoms, creating profound challenges for families and caregivers who often experience their own form of grief and loss. Family members must adapt to changing relationships as their loved one gradually loses familiar personality traits, shared memories, and the ability to participate in meaningful interactions. The caregiving journey typically involves increasing responsibility for daily care tasks, decision-making, and emotional support while managing their own feelings of loss, frustration, and anticipatory grief. Caregiver burden in major neurocognitive disorder is particularly intense due to the progressive nature of the condition and the 24-hour care needs that eventually develop. Research consistently demonstrates elevated rates of depression, anxiety, and physical health problems among dementia caregivers compared to other caregiver populations. The chronic stress of providing care, combined with sleep disruption, social isolation, and financial pressures, creates significant risk for caregiver health problems and burnout. Understanding the stages of caregiving can help families prepare for and adapt to changing needs over time. Early-stage caregiving may involve gentle reminders, assistance with complex tasks, and gradual assumption of responsibilities for financial and legal matters. Middle-stage caregiving typically requires more direct assistance with daily activities, behavioral management strategies, and increased supervision for safety. Late-stage caregiving involves comprehensive personal care, medical management, and difficult end-of-life decisions. Support services play crucial roles in helping families navigate the challenges of major neurocognitive disorder. Adult day programs provide structured activities and socialization opportunities while offering respite for caregivers. Home health services can assist with personal care, medication management, and household tasks. Support groups, both in person and online, provide emotional support, practical advice, and connection with others facing similar challenges. Educational programs help families understand the disease process, develop caregiving skills, and plan for future needs. As care needs increase, many families must consider residential care options, including assisted living facilities with memory care units or specialized nursing homes. These decisions are often emotionally difficult, but may become necessary to ensure safety and appropriate care. Quality memory care programs provide specialized environments, trained staff, and structured activities designed specifically for individuals with major neurocognitive disorder. Legal and financial planning becomes critically important when major neurocognitive disorder is diagnosed, ideally completed while the individual retains decision-making capacity. Essential documents include advance directives specifying healthcare preferences, durable power of attorney for healthcare and financial decisions, and updated wills and trusts. These legal preparations ensure that the individual's wishes are known and can be honored as the condition progresses.